السلام عليكم ورحمة الله وبركاته. أعزائي الطلبة, our lecture today is about lung cancer. The objectives of this lecture are: first, to know the etiology of lung cancer; second, to know how lung cancer can present, the clinical presentation of lung cancer; and third, to know how to reach a diagnosis, how to diagnose the patients. It's an important thing. And lastly, to know the main lines of treatment. Etiology of bronchogenic carcinoma. Cigarette smoking is the most common cause, responsible for around 90% of cases. 90% of bronchogenic carcinoma are related to smoking. The risk is proportional to the amount of smoking and content of tar. As for more amount of smoking, heavy smokers, they are more liable for getting bronchogenic carcinoma. Death rate from the disease from bronchogenic carcinoma in heavy smokers is 40 times more than that of non-smoker. So that heavy smokers are 40 times exposed to get bronchogenic carcinoma and death from this disease than that of non-smoker. Risk decreases slowly after cessation, so that we encourage smokers to stop smoking, because the risk of bronchogenic carcinoma will be decreased, although it is slowly, but it will be decreased anyhow. 1 out of 2 smokers, they die from smoking-related diseases, not necessarily bronchogenic carcinoma. Other disease, smoking is responsible for other diseases like ischemic heart disease, carcinoma of the esophagus, and so on. 1 out of 2 smokers persons, every 2 smokers persons, 1 of them die because of diseases related to smoking. There is a lot of speech about passive smoking. Passive smoking, it means that the person is not smoking, but there are nearby persons whom they smoke and they are exposed to tobacco fumes. Passive smoking is responsible for around 5% of bronchogenic carcinoma. There are other causes other than smoking, but they are uncommon. The most common causes is smoking, including exposure to radon. A number of industrial materials are associated with lung cancer. Lung cancer is more common in urban than rural area, probably due to atmospheric pollution. Look, this is the main etiological factor for smoking, that is for bronchogenic carcinoma, that is cigarette. Look for this one who smokes, and there is clouds of smoking around his face, cover his face and nose, mouth. Yes, this is the etiological factor for bronchogenic carcinoma. Pathology. Lung cancer arises from bronchial epithelium. It's not from the lung parenchyma, from bronchial epithelium or mucous gland. Symptoms occur when a tumor involves large bronchus. Symptoms earlier symptoms occur where there is involvement of large bronchus. And the other way around, peripheral tumor, that tumors that arise from small bronchi at the distal part, they grow slowly and can reach large size with cavitation, resemble lung cancer with little or no symptoms. Though most symptoms occur when the tumor involves large bronchus. Common cell types in lung cancer include adenocarcinoma, 35 to 40%, squamous cell carcinoma, 25 to 30%, small cell carcinoma, 15%, and lastly, large cell carcinoma, 10 to 15%, so that the most common is adenocarcinoma. Clinical features of bronchogenic carcinoma. First, we go for local symptoms. First, common, cough. Cough, which is the most common early symptom on bronchogenic carcinoma, is that of cough, usually dry. Can be productive when associated with infection. Bronchogenic carcinoma can result in partial obstruction of bronchial tree and resulting in stasis, and of course stasis will predispose for infection. Usually cough in a bronchogenic carcinoma is dry, but if the patient gets superadded infection, the cough will be productive. A change, this is an important thing, that's a change in the character of a smoker's cough should attract attention to investigate for lung cancer. Usually smokers, they have cough. If they get a change in the character of their cough, you need to investigate for a bronchogenic carcinoma. Second local symptom is hemoptysis, coughing of blood, especially with central tumors, so that we have said already that tumors involving large bronchus give early symptoms. Hemoptysis occur more when there is central tumor involving large bronchus. Hemoptysis in a smoker should attract attention to investigate for lung cancer. If you face a patient who is a smoker and get hemoptysis, he told you that he's coughing blood, this should attract attention to investigate for bronchogenic carcinoma. Although there are multiple causes for hemoptysis, of course, but once he's a smoker and he gets hemoptysis, this will ring the bell, and you have to investigate this patient for a bronchogenic carcinoma. Other local symptoms include arise from bronchial obstruction. The tumor, as we have said, bronchogenic carcinoma arise from bronchial epithelium, and so that can result in bronchial obstruction. The clinical and radiological manifestation depends on four things. First, the site of obstruction, where this obstruction had occurred. Second, the extent of obstruction. Third, any infection, as we had said in the previous slide, that this obstruction, usually that's partial or complete, result in stasis, and the stasis is predisposed for infection. And coexistent lung disease. If the patient has a previous lung disease or associated lung disease with it, of course the symptoms will be more severe. Complete obstruction results in collapse of the lung, with shortness of breath, of course, and the mediastinum will be shifted toward the site of collapse, and there will be dullness percussion notes when you percuss that site of collapse. While partial obstruction results in monophonic wheeze. Why occur wheeze? Because there is narrowing, passage of air, so that there will be localized monophonic wheeze that fails to clear with cough. Of course, cough will not change it. Cough can sometimes change the wheeze if the cause of narrowing is due to secretion. But here the cause of narrowing is not due to secretion. The cause of narrowing is due to tumor itself. And impaired drainage resulting in infection. Now, this is an important thing. We said previously that changing in the character of cough in a smoker should attract the attention to bronchogenic carcinoma. And hemoptysis in a smoker should attract also the attention to bronchogenic carcinoma. Now we add for them that recurrent pneumonia at the same site or poorly responding pneumonia to treatment should raise the possibility of underlying pathology, including lung cancer. We need to ask ourselves why this pneumonia is recurring at the same time. We treat it, improve, and then reoccur at the same site. There must be an underlying pathology, and bronchogenic carcinoma is one of the causes. Or that we give the treatment and the response is not so that good. It means that there may be underlying pathology, and this may be, we said it's not definite, of course, this may be bronchogenic carcinoma. Stridor, which is hard in expiratory sound, not expiratory. Wheezing is expiratory sound, while stridor is inspiratory sounds. Occurs when larynx, trachea, means large airway, is narrowed by tumor or compression by malignant lymph node, whether they are subcarinal or paratracheal. All of these symptoms are due to bronchial or airway narrowing. Another symptom, local symptom, is breathlessness, shortness of breath. Shortness of breath in bronchogenic carcinoma can be caused by the following: either collapse of the lung due to obstruction, or pneumonia as a result of poor drainage, or by a tumor causing large pleural effusion when there is metastasis of the tumor to the pleural space or to the pleura, resulting in a pleural effusion, and this can result in shortness of breath. Or by compressing the phrenic nerve, resulting in a phrenic nerve palsy, and this will result in diaphragmatic paralysis, elevation of the diaphragm, and this can also result in shortness of breath. Shortness of breath can result from collapse, can result from pleural effusion, can result from injury to the phrenic nerve, or can be caused by pneumonia as a result of secondary infection.